Welcome to the Animal Heartbeat. This is the world's greatest and only podcast dedicated to veterinary cardiology. I am Kieran Bourget.
And I'm Jose Novomatos.
So our guest today is Dr. Ronald Li, Diplomate by the American College of Veterinary Emergency and Critical Care, an Associate Professor of Emergency and Critical Care at NC State. And Dr. Li directs the Li Comparative Platelet and Neutrophil Physiology Laboratory. Welcome, Ron, to the Animal Heartbeat.
Hi, nice to have me.
It is nice to have you.
Thanks for having me.
We will not edit this; it will be left in true to form. Ron, it's fantastic to have you on the podcast, and we were just reminiscing off camera, as it were, about days in Potter's Bar, and now you have your own lab, and I have an iPhone. Our careers have gone very different paths from residency days, but it's super cool to catch up and have you. We obviously, as cardiologists, our particular focus is going to be about ATE in cats. There's a whole heap other interesting stuff to talk about, but I think most of our listeners will be coming at this thinking platelets. We're thinking about ATE. So could we just start by talking about your first line treatment and first line prevention recommendations for ATE in cats?
I think the first line agent, right, for ATE prevention in cats, and we're talking about cardiomyopathy, I think it's still clopidogrel. Conditionally, I think that depends on the risk factors of ATE, and I'm sure we'll dive a little bit more into that. I think so. Clopidogrel is still, efficacious as a first-line anti-thrombotic agent in most stage B2 cats, ones that still have some moderate atrial function, no smoke or spontaneous echo contrast or intracardiac thrombus, because essentially we can't ignore, right, the prospective fat cat study that came out almost 10 years ago now.
It's that long, right? Yeah.
Yeah, right. A while ago, but demonstrated clopidogrel, right, with its superior to aspirin for preventing recurrence of ATE, prolonging survival. I think one thing that I always stress is that the fat cat study and later on the super cat studies all are looking at secondary prevention, right? Yeah. We're looking at a cohort of cats that already experience a thrombotic event, and we're essentially using these evidence as primary prevention. So we have to be a little bit more careful about that. And that's why I think clopidogrel, while it's a great first-line therapy, a one-size-fits-all approach probably doesn't work for every cat. And so our latest research also indicate that in cats with severe systemic inflammation, clopidogrel alone, right, isn't enough to inhibit platelet function in those population of cats.
Before we talk about dual therapy and the stuff you've been working on, at times I wonder if we should just choose rivaroxaban as first line, because as you were saying, and we would like to have your opinion on that, you mentioned the fat cat study. There was still a recurrence rate of like 30% of something like that, if I remember right. And so you and others have raised the question that maybe some of those cats were resistant to clopidogrel. So I think the first question I wanted to ask you, and for you to share with our listeners, is how frequently do you see clopidogrel resistance in cats? And if you can tell us a bit more also about the polymorphism that the team at NC State has described on one of the ATP receptors, and how do you put all that stuff together?
Well, I think in the earliest studies that we did, again, now 10 years ago, we routinely started seeing this resistance rate about 30%, right, in our study cats. And this is just purely based off platelet aggregometry. And later on in our 2021 study, actually characterizing this mutation, particularly the P2RY1 mutation, we found roughly around 20% of cats that were homozygous and nearly 50% being heterozygous. And in our latest study ongoing, these numbers are nearly doubled
That's
in
wild.
cats that are
That's huge, isn't it?
experiencing, known treatment failure. And so how we define treatment failure is that these cats experienced an additional thrombotic event, including recurrence or persistent smoke, intracardiac thrombus, as well as ATE or acute neurologic event, despite being on clopidogrel alone. And so this means that this receptor does impact the drug's efficacy. We're still not entirely sure how that happens, but certainly these data indicate that the polymorphism does have a negative impact on how cats respond to the drug.
Is there a difference between homozygous versus heterozygous?
I wish I can tell you the answer. I would say that the case series that we're trying to gather, the homozygous cases are definitely, we're talking about 50 to 60% of cats being homozygous with documented treatment failure. I think the heterozygous numbers are still about the same at around 50%. And so I don't think, right, I think homozygous cats are definitely much more affected than heterozygous. And so at NC State, we are offering this test commercially, and the indications for testing would be, again, if they had come back with treatment failures. So, for example, the B2 cat that's on clopidogrel for 6 months comes back to see us and now develops an intracardiac thrombus or has spontaneous echo contrast. And so in those cats, we would recommend testing. Knowing what to do with the data is also another challenge.
It's hard, isn't it? That translation between the prevalence of polymorphisms, the sort of theoretical effect on function, and then the clinical outcome. Because we'd love it to be really clear cut and directly linked, but it doesn't feel like it always is, does it? One thing I just wanted to pick up on was using the presence of spontaneous echo contrast to make a decision about, do we test for the polymorphism? Do we look for clopidogrel resistance? I find it so settings dependent. Sometimes the presence of smoke on an echo, I guess you could say that if it's present consistently, that's a strong positive. What are your thoughts on that?
I would say, given the limitation of biomarkers that we have, I think really is down to echocardiogram, right? To look at those risk factors. I would love to have a blood test that practitioners can snap, right? And that is an area that I'm actively looking at as well, right? Looking at some of the CBC ratios and looking at citrulated histones as a marker of neutrophil extracellular traps in the blood. Like really putting it all together. And I don't think there is a magic bullet at the end of the day. Yeah. I feel like it's going to be, right, multiple markers that would identify those cats that are at the higher risk of recurrence and failure to treatment. So at the moment, right, all I can go by is the published risk factors, which is echo findings.
Right.
Ron, just regarding, have you ever identified, or is there any known resistance to a direct oral anticoagulant, either rivaroxaban or apixaban? Because then I'm asking this because then if price would not play a role, and at least in Europe, UK, rivaroxaban is more expensive than clopidogrel, why would we not just use a DOAC as our first-line treatment?
Right. That's a great question. I think in a person, they would go directly to an anticoagulant, mainly because of the low shear environment in the left atrium. So they think that fibrin polymerization takes place first. I think cats are a little bit different because we have evidence that even clopidogrel alone can indirectly impact thrombin generation and fibrin formation. And I think based on, again, this is not clinical data, right? This is preclinical data that we have in our JVIM study looking at the dual therapy between with rivaroxaban and clopidogrel. In a rivaroxaban group alone, interestingly, we found platelets to be slightly more primed. They're slightly ready to be activated compared to cats that were treated with dual therapy. And my guess is that probably those platelets are have higher amounts of granular contents because they're inhibited by the time we extract from the body and we tested them. And so when we hit them with physiologic agonists in our laboratory, they were more reactive. That turns out to be more reactive than our placebo group or the dual group. So because of that, I'm a little bit more hesitant to just do a direct oral anticoagulant because I think those platelets are slightly more reactive. And we're talking about cats, which tends to have the most reactive platelets out of dogs, humans, for survival benefit. But because of that, I'm a little bit more reluctant to just start cats off a direct oral anticoagulant as a sole anti-thrombotic agent.
That's super interesting. And I think talking about looking at the platelet function and the platelet activity in there, I think most practitioners consider assessment of platelet function to be solely a research tool. Do you think it's something that has clinical application where it's available? And what are the issues that arise around availability of testing?
That's a great question. I would say that despite years of advances in platelet function testing, I think it's still largely limited to academia and referral institutions. I think one of the biggest limitations is that you have to test the blood fresh, right? And so the blood, even just being transported, exposed to variable storage temperature will change the assay. And as I mentioned previously, cat platelets compared to humans and dog platelets are way more reactive and sensitive to in vitro changes. And so that makes it really hard to test, right? We have aggregometry, flow cytometry, p-selectin, and platelet works. But all those requires fresh samples, which makes testing this in general practice really difficult. I think out of all these tests that I mentioned, the assay called Platelet Works probably would be most applicable in general practice because all they need is a specialized blood tube. And that needs to be validated in across multiple CPC counters, right? Not just one or two that was published.
I thought that tag was always a mess, depending on which reagents we used and then so on. It felt that there were so many factors affecting tag. And then when VCM came along and we could use a fresh blood sample, I thought this would be great. So VCM might be the answer, or it might be easier, or we can have a more reliable sample. Can we assess platelet function with VCM, or what's your experience with VCM?
Yeah, I would say both are probably not particularly sensitive to assessing platelet function, especially assessing ADP receptor blockade. We did show some differences in certain TEG variables when we did our VCM versus TEG study in cats. What I want to emphasize is that there's been a lot of studies coming out looking at hypercoagulability or lack thereof in cats, right? Whether with congestive heart failure or ATE. And as you said, it's a mess. I think the usefulness in assessing overall hemostasis in cats is limited. I think part of the reason is that we're using reference ranges in healthy controls. And part of me feels like the reason why we're not seeing hypercoagulability is the rheology of the blood is a little slightly different, right? Like, so I think the plasma portion is likely different. I don't know. I just don't feel like we can compare these cats to healthy controls as a good reference range. And that is why we get studies that says, oh, these cats are not hypercoagulable based on VCM and TG. And I feel like that's false, right? We know these cats are ticking time bomb. And yet, we have papers saying, hey, you know what? They're not hypercoagulable based on these two assays that are not sensitive, in my opinion.
Yeah, I mean, you can't look at some blood work and say, oh, yeah, they're definitely not hypercoagulable when they've got a thrombus, because the thrombus tells you they're hypercoagulable, doesn't
Right.
it?
They already have they already have a thrombus, and so it's like, yeah, clinically they are hypercoagulable.
Mm. Yeah, I guess as you say, it comes down to sensitivity of the tests that we have. What just caught my attention there was you talking about sort of rheology and the kind of the science of flow of the blood. And obviously, what we're doing with these tests is we're taking the platelets out of their normal environment. So we're not looking at them in the context of the endothelium or of flow within the heart or capillaries or whatever. Is there any technology out there that looks at platelet function or coagulation generally in the flow environment?
Yes, there is. And so it is available for research only. So there are two ways that you can do it. One is very bench top way where you create flow chambers and assess interactions of cell types. So, for example, platelet interaction with endothelium under flow conditions, and you can manipulate your rheology by introducing pathologic shear. You can certainly do that. Or there are more sort of point of care tests that you can just purchase these chips and you basically place in whole blood and you assess platelet function. It's sort of like a fancy, platelet PFA 100. So the platelet function assay 100, where you're testing out platelet function under flow conditions, which is way more physiologic, right, than a VCM or TEG that is almost static, right?
Going now to the DOACs, the direct oral anticoagulants. I think the majority of people here in the UK would use rivaroxaban, not much apixaban. But besides the frequency, that of course rivaroxaban is SID, apixaban is BID, is there any other advantage of rivaroxaban, especially when combined as dual anti-thrombotic therapy? I believe you have been working on that, comparing clopidogrel with rivaroxaban versus clopidogrel with apixaban, right? Is there one combination that is better than the other?
Yeah. So obviously we don't have clinical comparisons. That would be fantastic. But our recent abstract at ACVIM, we compared dual therapy, right? So clopidogrel with rivaroxaban versus apixaban. And we did a crossover study in our cats, and we demonstrated differences in platelet function and platelet-dependent thrombin generation in rivaroxaban versus apixaban. And what we found is that the published dose of apixaban, which is 0.5 milligrams per kilogram BID, does not have clear synergistic benefit compared to 2.5 milligrams orally once daily of rivaroxaban and clopidogrel. I think the reason why is probably the anti-10A effect isn't high enough with the 0.5 mg per kilo dosing. And so persistently, we found that it underperformed compared to rivaroxaban clopidogrel in terms of reducing platelet activation, reducing thrombin generation kinetics. And so still, I think if that study comes out, we would still recommend clopidogrel plus rivaroxaban. So there are some patients that we would recommend apixaban, and those are cats that perhaps have CKD. And so because rivaroxaban itself is excreted unchanged, 65% of it by the kidneys. And so in those cats, the risk of bleeding is higher. And I would love to tell you, does dose reduction work in cats with kidney disease? I don't know. But I do warn the owners a little bit more, like about looking for potential bleedings in cats with CKD. And if they're really worried, we would switch them to apixaban, which is metabolized by the liver.
And you would go with the same dose or higher, sorry, for the apixaban in those cases?
Well, yeah, that's a great
0.5.
question. I
Yeah.
think previously I would say let's go by the published dose of 2.5 milligrams. But sorry, 0.5 milligrams. But
Yep.
depends on the clinic. I would start at 0.5 and then see clinically how they do. I think even going up to 0.75 to 1 mg per kilogram likely would be safe in those cats. We didn't see any bleeding again in this study. No bleeding diatheses that we could see.
So just a couple of things you mentioned. One, you mentioned anti-10A. And most of our listeners are probably familiar with apixaban and rivaroxaban being these oral anti-10A agents. And when we're thinking about treatment, should we be considering monitoring the efficacy of these drugs by using measurement of anti-10A activity?
Yeah.
Or is that a step too far? I mean, it's not available as far as I know in the UK. I think we just have to send it to the US if we want to measure that.
Right. If you asked me that question a year ago, I would say yes, absolutely, do 10A. But I think as we are doing more and more research in this area, we found that the 10A actually, even though it correlates really well with the amount of drugs in the blood, at the end of the day, it actually doesn't really correlate with hormone generation, which is the gold standard in assessing factor 10 inhibition. And so the same results goes for the dog study that were recently published comparing apixaban and rivaroxaban. The 10A levels tends to be kind of all over the place. There's a lot of individual variability, but at the end of the day, despite 10A being all over the place, their hormone generation are uniformly depressed, decreased. So I think we found the same thing in our previous cat study and also the current abstract as well. So my feeling towards routine testing of 10A, I'm less enthusiastic about it. I guess in humans, it's the same because the PK/PD effects are so predictable that they don't routinely test for 10A in humans. The only time they would test for it is when they realize your GFR, your kidney function, are decreased a little bit. Or if you have GI diseases, kidney disease, or renal disease, that you're at higher risk of bleeding, that's when they would test for your 10A.
So it's that.
Yeah.
It's that kind of comorbidities inducing that individualized medicine, then I guess, isn't it?
Yes, yeah, right. That's the key word. Is that again, right? A single dose, one size fit all approach probably isn't the best way. And we all know, right? We see cats with various comorbidities, and so that affects drug levels and efficacies of our direct oral antagonists. Yeah.
Right. Until we are at that stage of precision medicine and as we may not be able to measure really the activity of 10A and so on, what should we do? So what's our position in terms of dose increase with rivaroxaban? What I mean with this is when we have cats on dual anti-thrombotic therapy, clopidogrel and rivaroxaban, and we still see a huge increased amount of smoke, and we are still very worried with those cats. Or we see a clot now, we see a thrombus now in the left atrium. In some cases, we have increased the rivaroxaban dose from SID to BID. Does that make any sense, or we just don't know if that's helpful?
Yeah. I would like to say we don't have enough data to say that it's useful. But based on the pharmacokinetic study, it does make sense that they are treated twice daily, mainly because it does not really provide a 24-hour protection if you dose them once daily. I think the once daily dosing at the time was recommended because of the costs associated with rivaroxaban. And so a lot of owners here, especially in North America, um, it becomes cost prohibitive over time, right? If we start off rivaroxaban as twice daily dosing. So currently, what our recommendation is, we still start off with once daily with rivaroxaban and clopidogrel and monitor. Again, most of the monitoring that we do would be echocardiogram for recurrence of risk factors. And I think, especially if their mutation comes back as positive, let's say you have a cat already on dual, comes back to you, has developed a thrombus, and we test their P2R1 mutation and it's positive, those cats we would put them on twice daily rivaroxaban. We still don't really have good enough evidence that dose escalation of clopidogrel would be effective in these cats. This is an area of active research for us. And so it would be nice if, right, it would be nice if we can actually dose escalate clopidogrel, but I don't think that's the answer. And so at the moment, our best evidence is, well, we can provide adequate protection within a 24-hour period by dosing them twice daily with an antiplatelet drug.
Cool.
I have a couple of questions about other treatments that in the past people have relied upon, maybe before we were using clopidogrel. One is aspirin. I appreciate the supremacy of clopidogrel over aspirin. We know that from the Fat Cat trial, as you said. But is there a place in using dispersible aspirin for palatability, practicality aspects in cats who will not tolerate clopidogrel medication with tablets or the anti-10A tablets? And the second question is about heparins. This is a question that I get asked a lot. If I do electron ATE or something, people often say, what about injectable heparins, unfractionated or low molecular weight heparins in those acute ATE cats? Is that something that you would consider useful to reach for people in clinical practice or not?
So I guess my experience with unfractionated heparin in cats are a little bit limited. I think, when we start our residency already, there's a shift towards low molecular heparin. That doesn't mean that it doesn't work. It works, right? I think the effects of it is just a little bit less predictable than low molecular heparin, and I think that's why people are scared of it. Does it still have its place? Yes, absolutely. And I think depends on hospitalized cases, right? So if the cat comes in with ATE in respiratory distress, I'm not going to pill this cat, right? And so in those instances, we would choose low molecular heparin. There are a couple of studies that came out looking at using low molecular heparin as a CRI. And so I think that area is interesting. And, if someone wants to do that study, it makes sense. I know some of my colleagues in Japan and Korea are using it as a CRI. We certainly need more data in terms of looking at the anti-thrombotic effects and 10A and see if it's much more consistent and stable than intermittent injection. So yes. To answer your question, yeah, I think it still has its place. And we have not completely abandoned low molecular heparin. In fact, a lot of times we would start them off with low molecular heparin while they're in hospital because we have the luxury to dose them every 6 to 8 hours while they're in hospital. But once they get home, it becomes a burden, I guess a barrier for a lot of owners to dose them that frequently. And so in those cases, I would prefer them having a once daily pill. At least I know that it's working and the owners are giving it.
during my residency, would use unfractionated heparin all the time because we felt like at least we know it works. And I know we never know how much active heparin we might have on unfractionated heparin. But my feeling also looking at the studies of low molecular weight heparin is, do we really know how frequently do we need to give it and so on? So
that's always my worry with it as well. It seems to be very variable.
Yeah. Is there, so Ronald, do you think, is there still a role for unfractionated heparin? Would you ever use it, or would you favor low molecular weight?
I think that's based on comfort level.
Yeah.
And I think unfractionated heparin works. The only thing is that we've been taught that whenever we use unfractionated heparin, we have to monitor, right? And so testing for ABTT. And so I think because of that, many people moved away from that to low molecular heparin. And I say when we use low molecular heparin, I would choose enoxaparin over dalteparin, mainly because it seems to last a little bit longer in cats. But even still, right, we're talking about an anti-10A effect that doesn't really last beyond 6 hours for enoxaparin. It's entirely, I think it still works. It's just entirely based on people's comfort level, and the risk of bleeding might be slightly higher, right, in unfractionated heparin because of the variability of its pharmacodynamics. Yeah.
And is there a place for aspirin anymore in the sort of palatability or compliance stakes, or should we just move beyond aspirin because of a lack of efficacy or risk profile?
Does it still has its place? Absolutely. And so we just published a paper looking at the effects of endotoxins and toll-like receptor 4 in feline platelets. And so we know that platelets are immune cells. They have all the right machineries as the proper immune cells. And the difference is that platelets are the bridge, right? They're the bridge between innate immunity and thrombosis. And so in that study, we found that upon exposure to platelets, to endotoxins, which activates their toll-like receptor 4, it stimulates a lot of thromboxane A2. And this is the pathway that aspirin functioned to block. And I would say the indication for aspirin probably would be cats that you find have high risk of thrombosis, and you think that they have TMT, or your transient myocardial thickening. And we demonstrate that in our previous study in cats with the wildfire injuries. Now, those cats are very inflammatory, but almost half of them have intracardiac thrombus and smoke at the time of diagnosis.
That's wild, isn't it? Amazing. Yeah.
Yeah. And their platelets function very differently from your routine HCM group. They certainly have a much more potent response to arachidonic acid. And so, which is a pathway that aspirin blocks. And so I think if you think your cat has underlying inflammation, or there's high systemic inflammation, and it's not your run-of-the-mill HCM, right? We think it's perhaps a transient myocardial thickening, and you see smoke or thrombus, I think aspirin does has its place in those cats.
Very, very, very interesting. Very interesting.
Yeah, very interesting.
Yeah. Regarding doses, you touched on clopidogrel dose before, and this is a question we get all the time. Even like on the panel discussion at the World Feline Congress last weekend, we got this question again. We get it all the time.
When we're all doing different things.
Exactly.
It turns out.
Yeah, true. But regarding loading dose, I think after the ACVM guidelines for feline cardiomyopathy diagnosis and treatment suggested a loading dose for clopidogrel, I think many people have become interested in these. So do you think is recommended to give a loading dose of clopidogrel? Do you do it? And what's the advantage? How much faster would we have an antiplatelet effect if we load a cat on clopidogrel versus just give it a standard dose?
I think there is very limited evidence in that. And it would make sense, right? If a loading dose will theoretically accelerate inhibition in high-risk patients. But what we need is a prospective trial looking at that. I do
Yeah.
not load routinely, but in high-risk clopidogrel naive cats, I would do half a tablet. So that's roughly around 7.5 milligrams per kilogram tablet on the first day. It would make sense because you bring their active metabolite up quickly, and then going back to the maintenance dose. But really, there's no evidence in this.
Obviously, we're inhibiting platelet function deliberately in these cats. Let's say they come back in with a pleural effusion. They're on clopidogrel. How concerned would you be about a risk of bleeding associated with thoracentesis? The second part of that question on the same theme is a cat who is in stage B2, HCM, solid B2, diagnosed by a cardiologist, poor atrial function. They've got risk factors. They're on clopidogrel at a standard dose of 18.75 per cat once a day. They need dental work as a quality of life issue. What are your recommendations and your perspectives around discontinuing clopidogrel versus continuing it through? I know there are curative guidelines out there from 2022. Is that right? In JVEC? But I'd be interested to hear your thoughts.
Right. So first question is bleeding risk. And I think the current evidence is reassuring, but limited, right? Because we don't have a lot of evidence in clinical cats.
Yeah.
So far, we think that bleeding complications are limited. Compared to humans, rivaroxaban seems to be well tolerated. Because in human medicine, rivaroxaban does cause more bleeding than apixaban does. In terms of procedures for thoracentesis, I think currently the risk is low for bleeding. What I would recommend is, I don't think, because it's a one-off procedure, I don't think practitioners should discontinue both drugs before doing thoracentesis. But let's say you're coming to see a recheck appointment with you guys, I would probably wait, right? Maybe appointment time, let's say you anticipate to do some procedures on it. Maybe it comes back with pleural effusion or something. Probably hold off on the rivaroxaban dose, right? Because we know it peaks at 3 hours and 4 hours. And so if at that time, if you do thoracentesis, the risk might be higher, right? They can always redose it right after, right? And adjust the time thereafter. And so if we're really worried about it, try to avoid that 3 to 4 hour period, peak effects after oral dosing. But I would not discontinue antiplatelet drug, right? I would continue that. In terms of the B2 cat that's on Plavix getting a elective procedure like dental, I would not recommend stopping it, mainly because I think even human medicine, right, the risk factor trumps the benefit decision, right? So I think, I don't see any value in discontinue clopidogrel in those cats. The good thing about any sort of oral procedure is if they provide really good hemostasis controls, they should be able to stop the bleeding during dental. And so in those cases, I don't routinely recommend discontinuing clopidogrel.
I'm gonna tag a short clip of this podcast and play it to my dentists I work with. Because they worry a lot about this, and I think it's something that a lot of GPs worry about. And I guess people who have got strong interest in cardiology, they're prescribing this clopidogrel, and their colleagues in general practice or primary care practice might say to them, what do I do? So I think it's easy to worry, isn't it, about these cases?
It's always, obviously it's weighing risk and benefit, right?
Exactly.
I think, it's a difference between doing a dental prophylaxis versus a full mouth extraction, right? Right? Like if it's a full mouth extraction, would I discontinue clopidogrel? Depends on the degree of heart disease, right? If we think this cat has a high risk of thrombosis, I still won't recommend discontinuing it, and perhaps have more topical control. We can do that. I don't think, there's a correct answer for all patients.
Yeah, it's good though to emphasize that, I think, because I think the lack of there being a sort of blanket policy
Yeah,
probably is reassuring
absolutely.
for people who face these
Right,
dilemmas.
right.
Those are great tips, really. Just as you touch plurifusion, and we were talking about thoracocentesis and so on, your group and others have suggested that maybe cats with congestive heart failure with plurifusion have a lower risk of ATE than cats that have pulmonary edema, so they'll be less prothrombotic. Can you explain us that? Why would that be? What are the mechanisms and what your data has shown?
Yeah, and I think the evidence stems from the retrospective study that was published,
Yeah.
and also based on um, human data, right? That pleural effusion and pleural fluid tends to have a lot of fibrolytic proteins that gets reabsorbed, and so the chances of thrombosis in cats with pleural effusion tends to be lower compared to pulmonary edema. Um, I think one thing that we have to be careful when evaluating that study was they didn't really separate pulmonary edema from ATE groups. And so I think I think that creates a bit of a problem when it comes to looking at that data set, because a lot of, and you guys would know this better than me, that when's the last time we saw pleural effusion cats come into ATE? Almost never, right? Like most of the ATE cats come to us with pulmonary edema.
Yeah, and I often wonder if that's secondary to the ATE
Yeah,
because
I
of the
think so
stress,
too.
the
I think
vasoconstriction.
so. I
Yeah.
think so. And so in that case, in that retrospective study, they grouped them as pulmonary edema.
Mm. Yeah, and I think I guess, we know that cats with pleural fluid have got worse left atrial function. We know
Yeah.
they've got, a lower MAPC, if you want to, look at that. And I think, I guess that lower function might also be a predisposing factor to ATE. So it's quite hard to tease that out from retrospective data, I think.
And it's really so yeah, and so what we're trying to do is assessing coagulation holistically, right? So we're looking at primary hemostasis, we're looking at global hemostasis, and we're looking at particularly fibrinolysis in these two groups of cats. Again, fibrinolysis is something that is very difficult to measure clinically. You can certainly measure it using TEG. In itself is limited. And you can do plasma-based assay, also looking at individual pathways of molecules. Again, it's a very difficult process to evaluate. What we found so far is that there seems to be little differences between the two groups. What I can glean from that set of data is that, again, each cat are very different. Despite them being in two different groups, it seems to be related to their disease severity at the end of the day. So when we do our something called overall fibrinolysis potential, which we challenge their plasma with TPA, we see equal numbers of responders versus equal number of non-responders in both groups. So that to me is interesting because that kind of explains why TPA is so variable and why it doesn't work in some cats and why it causes bleeding in some cats, right? So again, I think that that goes back to the precision medicine part, right? That I don't think um, it's as simple as effusion versus edema.
You mentioned TPA, uh, and I think many people are familiar with the idea of clot busting, thrombolysis. And I know historically, people have looked at TPA in cats, in all cats with an ATE, irrespective of duration of the event or duration of the signs, sorry. And things like streptokinase. And the impression initially was these drugs might have had negative results, but the more recent BLAST trial, which I know was published in the Journal of Feline Medicine and Surgery, suggested that for acute ATE, TPA treatment wasn't associated with an increase in risk, but also was no better than standard therapy. What are your thoughts on TPA and other drugs that might be considered these sort of thrombolytic agents? Is there a place for that in managing these cats?
Oh, this is very controversial.
We love controversy. We welcome controversy.
I am afraid I'm unable to provide an unbiased answer.
We also love bias as well.
Well, I think to look at this, we have to look at the stroke data in humans. And I think TPA treatments in stroke patients in humans is controversial. That 3-hour window period is controversial. Many people who study thrombosis think that TPA, even by 3 hours, is useless, right? So unless it's a truly acute event, I think TPA has its risks and potential harm, right, that you can cause. Now, trying to translate that to feline medicine, how confident can we say that the cat has a thrombus within the 6-hour window? I'm not confident because I think that a lot of times those clots are probably minor and we miss it. Not until the clot has grown big enough that it's causing complete impedance in blood flow, where the cats are showing clinical signs. And so I think that's one major limitation of us utilizing TPA within that golden period. And we kind of stretch up to 6 hours, which, right, I won't comment on that. But how I approach this is weighing the advantages and disadvantages, right? And I feel like if we look at the data in a little bit closer, the TPA group seems to have a higher incidence of hyperkalemia, AKI, and reperfusion injury, even though the p-value isn't different.
It's not a huge study, is it? I mean, it's still a small number of cats, as most of these veterinary studies are.
So what I can gather from that is I am going to give a very expensive drug that has life-threatening complications with unknown efficacies and advantages. That puts me in the no category more often other times. That being said, I think the dose that was chosen was probably very conservative. You know, I think we can at least be comfortable that, you know, all these cats don't clinically bleed out, but still, I think it's something that I really talk to owners carefully about. It's not something I pull and use lightly.
That's hard, I think, to really feel like an owner in that challenging situation where you're saying, look, we don't have the data, we can try. I think ultimately they're so worried, stressed, emotional because their cat that seemingly was fine that morning, they've come home from work and the cat's not walking and is screaming in pain. That's a hard situation to make those sorts of decisions, I think. So I think it does sort of come down to our guidance, and that's difficult when we don't have a clear consensus.
To me, has always been what, Ron, just to echo what you said, that very narrow window that they have for stroke patients, that in every country they will know where is the closest stroke unit to bring a patient straight away to the next stroke unit, because they know so well from time to needle or whatever the name is, since they from like the admission to needle, the time that they take to receive TPAs or other drugs, it has such a huge impact. at least the case we see here, 6 hours. If we see the case within the first 6 hours, is good. Will be amazing, because from the time, as you were saying, that the owner detects that the cat is not well, going to the referring veterinarian, being referred to a center, it's certainly will not be able to do that within those very narrow windows. But what you raise even another question is, when we diagnose those cases, the clot has been there probably already for a couple of hours at least. So I always have been very pessimistic about it, just especially because of that very narrow window for TPA or other drugs to have an effect.
Yeah, and there is a researcher that does this type of research in dog stroke models, and what they found is that as the clot is formed, the longer we wait, the more from real manufacturers, neutrophils are coating those clots, which prevents TPA from penetrating into the clot. And so which renders it less efficacious than in the acute setting. Yeah.
And do you think there's a difference? This may be a really ignorant question, so I sincerely apologize if it comes across stupid. Do you think there's a difference between thrombosis in situ and thromboembolism from the point of view of that acute treatment? Because, we're talking in cats about thromboembolism, I guess in almost all cases. We are presuming the thrombus has occurred within the left atrium, and part or all of that thrombus has embolized to a systemic artery, and then we see that affecting the limb acutely in almost every case.
Yeah.
That's different to a sighthound who has got aortic thrombosis, probably at the aortic, the terminal aorta, aortic trifurcation or whatever.
Yeah.
Is there a difference in how we should be thinking about those cases from a treatment perspective?
Wow, that's a hard question. I think, yes, absolutely. I think a clot that is formed, embolized, to distal arteries, I think the composition immediately changes. And so you go from a highly fibrin-rich clot at the site of the left atrium, and then the instant that is exposed to abnormal blood flow and high shear stress, that's where a lot of the neutrophils and nets and platelets starts coating that thrombus. And so it's interesting because the fact that our routine therapy still is the same, regardless of where that clot is. I actually don't know. I don't know how we can target clots that are formed in the heart versus clots that are formed in distal artery. My guess is that the immune thrombosis, an immune component of platelets, once they are at a location where there's a lot of neutrophils and the shear stress is high, function differently. And so there are probably other pathways that can target in clots that are formed in arteries versus clots that are formed in the left atrium.
Bit of a random question, apologies, but I feel that they must be different because circumstances are different.
I don't want to bore you with the science. But
it would go right over my head, I suspect.
We're about to publish a paper on specific immune function of platelets in interaction with histones and citylated histones that we know are increased in cats with HCM. And what's interesting is that our routine therapy, we're talking about clopidogrel and aspirin, are unable to shut down those priming signals. And one potential areas that we're looking at is phosphodiesterase inhibitors in platelets specifically, because we know that that's one inhibitory pathways that's shut down in histone-activated platelets. So that's to come, and then I think hopefully we can do a little bit more preclinical work in that.
As you mentioned HCM now, Ron, there's been some maybe contradictory data in the literature if cats with HCM are hypercoagulable or no. Can you tell us more about that? Do cats with HCM have an increased platelet activation and priming, potentially even before they develop HCM? So is that real? Are cats with HCM hypercoagulable? What could the mechanism be? Why would cats with a sarcomeric mutation and thick walls be hypercoagulable?
I think there's a subset of cats that probably has chronic inflammation that we're not aware of. And I think we're repeatedly demonstrating that in our proteomic study, in our just a simple CBC study, that they have, right? They undoubtedly they have a higher neutrophil lymphocyte ratio, right? And very, very early on during diagnosis, whether that's physiologic stress, low-grade systemic inflammation. So I think it's because of this imbalance of inflammation and anti-inflammation that triggers thrombosis. That's one. Two is that the two systems talk to each other, right? So if there's systemic inflammation, then we have hypercoagulability. From the platelet standpoint, right, I think the changes in how blood flows through the heart, you probably know this better than me already, then it changes, right? It changes how platelets behave. And it changes how platelets are produced at the level of bone marrow. And so I think it's multifactorial, causing these cats to be hypercoagulable. As I mentioned before, cats tends to have the most reactive platelets compared to dogs and humans and pigs. And so I think that makes them great to study. Terrible disease, obviously, but I think it's just manifested as a very life-threatening thrombosis that we don't tend to see in dogs.
I guess that's the $1 million question for the listeners. You talk about stroke in people. Atrial fibrillation is a major risk factor for stroke in people. Dogs have atrial fibrillation all the time. It's the most common arrhythmia. Dogs very rarely will have aortic thromboembolism, cardiogenic aortic thromboembolism. Cats never have very rarely have atrial fibrillation and have a very high prothrombotic risk. I'm picturing it like that because whenever we talk about physicians and we think about translational cardiology and so on, they're always very surprised that dogs with AF will not develop clots and cats without AF and HCM. Atrial fibrillation is also very, very important in people with HCM. So what are your thoughts on that? Is just because their platelets are more reactive, or is there other reasons of why cats will more easily develop clots versus dogs versus humans?
I think one is the unique platelet biology in cats versus dogs. Cats' platelets tends to be much more heterogeneous in size and bigger. And we know that the more hyperreactive they are, the bigger the platelets. And so that contains much more protein content and mitochondria than smaller platelets, like in humans and dogs. So I think that already puts them at a place where when homeostasis is thrown off, they become prothrombotic. I don't really know why dogs with AF don't have thrombosis. I think that's $1 million question compared to humans. You caught me there.
We get you in the end. I remember speaking to somebody, and I think it might have been Adrian Boswood actually, talking about the same topic. Why don't dogs with atrial fibrillation get or appear to get an increase in risk of thrombosis? And one of his theories was to do with mitral regurgitation and the fact that it's really common amongst dogs with AF to have mitral regurgitation. And therefore, that increase in flow within the atrium is very different to the cats with a large auricle and a sort of blind ending, poorly functional sac there. So that was one of his theories. And I guess that's a nice story. It's a nice idea.
Do they actually always, do they actually have lone AF? Do they truly have lone AF, or do they always have
Yeah, well, that's a.
underlying?
I
Yeah,
think you've got us there.
yeah. The matter regurg, I think that's documented in humans. So as the matter regurg kind of washes the left atrium, people with matter regurg are less likely to develop clots. But then, as you're saying, we have like the Irish Hawkhound with lone AF. Those guys would be at high risk. Maybe their left atrium is not huge, but they have AF. And people like the classic cause of cryptogenic stroke in young adults is because they have transient intermittent AF, so they will have nearly structurally normal hearts. And DCM dogs, right? Dogs with DCM with barely no MR, you would still expect them to develop thrombus, which they.
There are definitely case reports out there, aren't there, of dogs with cardiac disease or particularly atrial fibrillation with an intraatrial thrombus. I seem to remember
Horses get it. Horses don't get it. Like horses AVIP, but they don't.
Yeah, that's another good point.
They have rouleau formation all the time, right? You see that spontaneous echo contrast, but because of rouleau in horses. It's super interesting. I've definitely seen one dog with atrial fibrillation, a dog de Bordeaux. This was during my residency run, so I may have spoken to you about it 4 million years ago when we worked together. But I think that dog was a dog de Bordeaux with atrial fibrillation and a heart rate in clinic of 300 nearly. And you know, I mean, of course, there was stagnation of flow in that dog. And what we did was we treated the AF. We treated with clopidogrel, rightly or wrongly, and the dog came back and the thrombus was gone. I think it's an interesting area.
Ronald, regarding new treatment and new drugs and so on, of course, everyone is very excited about rapamycin in subclinical HCM. And you have also been working with rapamycin, looking at the effect of rapamycin on platelet function and coagulation. Can you tell us more about it? Because I guess the dream would be we have one tablet that you give it once weekly and it does it all. And so is there hope for that? What did you find so far of the effect of rapamycin on platelets and coagulation?
Right. So the study that we did was ex vivo study, again, testing for delay-release rapamycin. And so what we found is that it did not produce clinically important alterations in platelet function. But what we found is that it has a protective effect in platelet mitochondria and how platelet responds to stimuli that would push them into a phenotype called procoagulant platelets. And so procoagulant platelets are a subset of platelets that are not targeted by conventional antiplatelet drugs, but are pretty important in stimulating thrombin generation and systemic hypercoagulability. And we know that certain disease states, environmental factors, age, all plays into a role of how platelets can morph into these procoagulant platelets. What we found is that within the 72-hour period after dosing of rapamycin, the mitochondria seems to be stable, and platelets have a lot of mitochondria. They play a very important role in calcium handling and the phenotype of platelets, whether they're turning into, we call them zombie platelets or the procoagulant platelets. And so whether they morph into that procoagulant phenotype. And so we know that within the 72-hour period, that seems to be stabilized after rapamycin. Whereas the other phenotypic markers of procoagulant platelets are shorter. We're talking about maybe 24 to 48 hours after the last dose of rapamycin. So certainly, I don't think it's a silver bullet. I think it does have potential synergistic effects with antiplatelet drug. How does the effect last longer than 70 hours requires probably further clinical studies.
Yeah, it's an exciting time, isn't it, with these additional things on the horizon that may benefit, the disease, but also the consequences of the disease.
I think we have a common theme here that I think we're moving away from the one-size-fits-all approach. And I think the future is looking at multiple biomarkers, be it echocardiographic markers, blood work, novel protein analyses to look for high-risk patients, precision medicine guided therapy, genetics involving as well, and then new anti-thrombotics. The drugs that we're using have been used for decades, right? And so we haven't found really novel therapeutic targets specifically for cats with ATE and HCM. So I think that these are the sort of common goals that I have in my lab.
Looking at the future and looking at all, as you were saying, all new drugs that are available in humans now, is there one drug that you are especially excited about that you may feel like this might be useful in cats in the future?
What is the silver bullet, Ron?
Exactly.
There is no silver. Well, in human medicine, they're starting to look at novel factor 11 inhibitors, especially in children, right? And in cardiovascular procedures, they tend to have a lower bleeding risk than the current anticoagulants that are being used. And so I think that's also an area of active research. I think thrombin inhibitors as well, adaptive human medicine. And then, well, not to bore you guys as well, but there is some very interesting novel therapies called RNA aptamers. And so these are molecules that are like RNA, pieces of RNA that are altered, and they're stable in the cardiovascular system for a certain period of time. These molecules can be reversible and can inhibit von Willebrand factor for a very short period of time. And so in preclinical trials in dogs and humans have shown to be more efficacious than TPA in restoring collateral circulation in stroke models. And so these RNA aptamers seems to be something that's very novel and something that we can use because it doesn't have that bleeding risk that TPA has.
I think that's really interesting, isn't it, about the data from people. And I just signpost any listeners who are interested in aptamers and the sort of science of that, the theory of that, to some work by Professor Vess's group on DCM and aptamers use in dogs with dilated cardiomyopathy. It's really interesting. It's pilot data, but it's a very interesting area, isn't it?
Yeah, absolutely. Hopefully we can do some work with some investigators at Duke, some preclinical work.
We've talked platelets, we've talked drugs, we've talked therapy, we've talked next generation stuff. So, Ron, thanks for joining us. It's been really fascinating. And it makes me want to go and read a little more about platelets and zombie platelets as well.
Thank you so much, Ron. It has been really a pleasure. Really very useful. Lots of tips. Has been great. Thank you.
Hey, thank you.
Hey, thanks again for finding the time to
you're welcome. Thank you.
Great. Cool.
Appreciated it. Thanks, Ron. Take care. Bye-bye.
All right.
See you later. Bye.
You have been listening to the Animal Heartbeat. If you would like to reach us, email us on animalheartbeat@gmail.com.
Remember to like, follow, or subscribe wherever you get your podcasts, and check out the website animalheartbeat.com.